Thanks for coming and welcome to our second State of Democracy lecture of the year, this one on the future of Medicare. I'm Grant Reher, Director of the Campbell Public Affairs Institute, and our principal speaker, Jonathan Oberlander, arrived here yesterday from North Carolina just as the snow started to fall. And so first, I'm grateful to John that he didn't just get back on the next plane and go back. He's still here today, so I appreciate that. Before I introduce him more completely, I want to offer some thanks first to the Dean's Office for supporting the series and for technical support, the Information and Computing Technology Group, and in particular Tom Fazio. I also want to thank my colleague Elizabeth Cohen, who helps organize the series, and Bethany Wallowender and Kelly Coleman, who work in the Institute and help put together these events. In addition, let me give you a brief preview of the upcoming speakers in the series for the spring semester. In January, Economics Nobel Prize winner Elinor Ostrom will visit, and she'll be followed then by the homecoming of our former colleague, Arthur Brooks, who is now the president of the American Enterprise Institute, and he'll be assessing the current state of American conservatism. Today we're going to return to our traditional format. You'll hear first from John, and then more briefly from two faculty respondents. And then John will have, even more briefly, the opportunity to respond to their observations. And following that, we'll then ask you to get involved, to pose questions to the group or offer points of your own. And then, of course, we'll continue the conversation out in the foyer over food and drink, where also John will be happy to sign a couple of his books that are out there for you to have a look at. First, let me introduce the two respondents. I don't really think we could have found two better qualified and better suited people to add their thoughts to this important topic today. And as always, they deserve a longer introduction, but I want to get us into the actual conversation as soon as I can. Tom Dennison is Director of the Program in Health Services Management and also the Director of the new Lerner Center for Public Health Promotion based here in Maxwell. He'll actually be speaking second of the two respondents. First respondent, John Palmer, is a university professor here at Maxwell. He's also a former dean of our school, but perhaps most notably for our purposes today, John served 2 terms as a public trustee for Medicare and Social Security from 2000 to 2008. Now to Jonathan Oberlander. John's a professor of social medicine and health policy and management at the University of North Carolina, Chapel Hill. He writes on Medicare and healthcare politics and healthcare reform more generally, and he's the author of The Political Life of Medicare, one of the 2 books that you will find outside during the reception. His other writings have appeared, among other places, in the New England Journal of Medicine and the New York Review of Books. As you might imagine, John's been constantly in demand by the media in recent years, and as I was saying to him earlier, if academic areas of interest were like the stock market, he'd be Apple. But as far as whether the stock of the Medicare program itself has a buy or a sell recommendation, I'm going to leave that to the expert to tell us. So, John, welcome to Maxwell.
Thanks, Grant, for the introduction. It's great to be back in Syracuse and an honor to be part of this series. This is a super exciting time in the healthcare system. It's a time of great change, a time of great turbulence in the system, and Medicare is caught up in that turbulence. I think it's no exaggeration to say that we've reached a crossroads of sort in the Medicare program. We've reached the point where we're going to be making decisions about which way Medicare is going to go. And the question is, what is the future direction for Medicare? And the problem is that the crossroads look a little bit like this. And what I'm hoping to do today is to clear away some of the confusion and some of the puzzlement about Medicare. Now, I have to say, when Grant asked me to talk about the future of Medicare, I was very excited because most of the time I'm talking about the past. And the great thing about talking about the future is I cannot be proven wrong. I could well be very wrong, but you won't know that until a few years from now, a decade from now. And by that point, and probably long before, you will have forgotten what I've said today. So I love talking about the future. But this posed a dilemma for me. How far in the future should I talk about Medicare? Medicare 3010, Medicare tomorrow, Medicare a decade from now. I'm actually going to do a little bit of each. And so I'm going to start out and talk about what's happening with Medicare right now and what might happen in upcoming weeks. And then I'm going to talk a little bit about the more medium term and what's going on in Medicare, and finally, the longer term, and that's where I'm going to focus most of my remarks on the financing challenges that lie ahead for Medicare. At the same time, what I want to do is talk about the forces that I think are going to influence Medicare over the coming years. And those forces include deficit and debt politics, which of course are quite visible right now. Those forces include the broader fate of the Patient Protection and Affordable Care Act, the health reform law that was passed in 2010, and Medicare, at least partly, its fate is linked to that. Those broader forces include demographic changes in Medicare and also what's going on in the broader environment, both fiscally and politically. So I'm going to try and weave all of that into my story. So let me start off by talking about the near term, the very near term. And what is hanging over American politics right now is the issue of debt and deficits. And you see before you one of the ways to express that problem by the Congressional Budget Office, which is showing the cumulative federal debt. And one way of looking at the chart is we have a lot of debt right now, a lot of debt. And if you remember back to the crisis on raising the debt ceiling we had earlier this year, part of the agreement was to create a congressional committee, a bipartisan committee, invested with superpowers to tackle this debt problem. And I have a photo of the committee right here. And probably, to be honest, and if you didn't grow up in the 1970s, this Hall of Justice reference may escape you, but I know at least Grant will get it. But these folks pictured up here probably would have a better chance at fixing the debt problem. One other point I want to make about the 1970s, most of these folks you're going to recognize, but look at these at the end here. I actually don't know who they are. I think the only superpower they have is they're wearing bell bottoms. So I'm not sure what that's about. But anyway, if we get back to the real super committee that's meeting right now, it's comprised of equal number of Democrats and Republicans, members of the House, members of the Senate. And they have until Thanksgiving to come up with a bipartisan plan to trim about $1.2 trillion off the debt over the next decade. As they look at plans and trimming the debt, healthcare is in their sights. And the reason healthcare is in their sights is that if you take Medicare and Medicaid together, they comprise almost $1 out of every $4 of federal spending. And so if you've been reading the paper in the last few days, you've seen that Democrats and Republicans have both put out, at least in secret, semi-secret, proposals on the debt to reduce the debt by substantially more than $1 trillion. And depending on what you read and what you hear, they would knock $400 to $500 billion off of projected Medicare spending in the next decade. So this super committee is, among other things, certainly looking at savings very seriously from healthcare. Now, I don't want to suggest that there's a good chance that these folks are going to stalemate and not reach a bipartisan solution. But there is a good chance they're going to stalemate and not reach a bipartisan solution. And those of you who have spent time in Washington, as I have, will recognize these streets in Washington. So what would happen if they fail, and there's a very good chance they're going to fail, if they fail to come up with bipartisan agreement, a compromise, what would happen is that a series of automatic cuts would go into effect, in theory at least, over the next decade. And it would take about $120 billion out of Medicare, projected Medicare spending in the next decade. Now, most people in the healthcare industry are actually rooting for failure. They're rooting for stalemate. And the reason they're rooting for stalemate is they think $120 billion is a lot less than what this super committee is going to take out of Medicare if they actually come to agreement. So if there is stalemate and failure and everybody is depressed about it, they'll be popping some champagne corks, at least in the healthcare industry. Now, I want to move away from the next few weeks and the super committee's attempts to find a solution to our debt problem. And I want to talk about the 2010 health reform law, the Affordable Care Act. And I do a lot of speaking and teaching about healthcare reform and the Affordable Care Act. And I'm always looking for visual aids to simplify what is a very, very complex law. And so here's one of the aids I found that offers a simplified view of healthcare reform. And Actually, I have fairly bad vision, as you can see, so I'm not sure how accurate it is. I think to the extent that I can read it, I think it's actually a fairly accurate picture of the Affordable Care Act. So let me talk. There's a lot to be said about the Affordable Care Act, and maybe we'll get into it later. But let me talk specifically about how it will affect Medicare. This, by the way, I was going to use as my final exam question for my students this semester. And I was just going to show them the slide. And if any of them can possibly divine what I was thinking when I put the slide together, I will graduate them immediately. I think the chances are low. But let me start from what is, I think, your left. The first implication of the Affordable Care Act for Medicare is that it's going to improve Medicare benefits. Medicare benefits have a lot of holes in them, and one of the holes that Medicare benefits has, quite literally, is in its prescription drug coverage. The infamous donut hole, and as we call it in North Carolina, and since y'all are joining the Atlantic Coast Conference, you need to learn these sort of cultural icons of the South. We call it the Krispy Kreme hole down in North Carolina. But there's literally a donut hole where the government stops paying for prescription drug costs for over $3,000 until it kicks in again, and it doesn't make any sense at all. And one of the things the health reform law is going to do is slowly, over the next decade, close that hole. Medicare beneficiaries are also going to get enhanced preventive coverage, as are Americans with private insurance. But the main effect and the main connection between Medicare and the Affordable Care Act is Medicare served as a great financing source. Covering the uninsured may be a moral imperative. It's also a fairly expensive thing to do. And about half the money that was used to expand health insurance coverage to the uninsured in this country was obtained by savings from Medicare. About $425 billion in 10 years, the Affordable Care Act gets out of Medicare, projected Medicare spending. That comes mainly from two sources, the hospital side and from what are called Medicare Advantage plans, which are private insurance plans that contract with Medicare. Now, that's not the only way that Medicare saves money, and I have to admit, during the health reform debate, it was a difficult time to talk about health care. I used to walk in and out of talks in camouflage, and I was confused because I was talking about health reform, about the Affordable Care Act legislation, and people were very fired up and very upset in all kinds of directions. And when I would talk about this one provision in Medicare, where they're going to set up this bipartisan commission, this expert commission to look at ideas for curtailing Medicare spending, people would cheer. And I didn't understand why this technocratic idea was so popular. And then finally I figured out that I was talking about the Independent Payment Advisory Board, the IPAB. They thought I was saying iPad, and they thought that part of health reform is we were going to give every American an iPad. That, by the way, would have been less expensive and more popular to do than the actual law. In any case, what the law does on the IPAB is it creates this commission. And it's an institutional embodiment of the notion that Congress can't do its job, that we have all these great ideas for changing Medicare spending, but Congress is permeated with interest groups and susceptible to the healthcare industry coming in and saying you can't adopt that change because it's going to hurt us. What the law does is it sets a trigger, a threshold for Medicare spending. And if Medicare spending goes beyond that threshold, then that commission is empowered to make recommendations to Congress. And if Congress does not act, those recommendations will become law. So that's the IPAB. The final part of this slide has to do with a series of changes they made in the law that are really experiments in Medicare and hopefully beyond, on how to change the payment system, how to change the delivery system. In other words, transforming how we pay and deliver medical care in this country. And maybe the reform that's gotten the most attention in this vein lately is what's called an accountable care organization, which you could define roughly as an HMO without the parts that people don't like, or you could define as, in theory, hospitals and doctors coming together and being paid on the basis of taking care of a defined population and being paid more if that population is healthier. Now, the thing about accountable care organizations, as Mark Smith from the California Healthcare Foundation has pointed out, they sound beautiful in theory. They look beautiful on a page. Nobody's actually seen one. Thus, they are, yes, very much like a unicorn. All right, so let me move on, if I can, from there, and now talk about what I really want to focus on, and that is the long-term financing challenge in Medicare. And this is a chart that has made its way around Washington recently. And an occupational hazard of talking about healthcare is that people always accuse you of being depressing or depressed, when in fact, most of us here in the field are not depressing. I don't know about depressed, but at least not depressing. It's just the news is usually bad. So I want to start out with some good news. Many of you have heard about the crisis in Social Security, and Social Security is going broke. If you'll look at this chart, you can see that you'll be able to sleep better tonight. What this is showing you is, over time, the percentage of all these different programs and how much of the economy, measured in gross domestic product, that they're projected to take up. Now, one thing I want to say at the start of this is that these are just projections. And when you get out talking 3-4 decades from now, you have to treat them with a high degree of uncertainty. Nevertheless, projecting Social Security is a little easier than some of the other things because it mainly has to do with the demographics. And it's true that Social Security costs are going to go up as a share of the economy over the next 2 decades, but they're not going to go up by that much, and they're going to remain fairly flat thereafter. So Social Security really is not in crisis. There is not a serious funding problem in Social Security. With some relatively modest changes, you can stabilize Social Security for a long time. If you look at the rest of the budget here at discretionary spending, everybody wants to cut discretionary spending. Well, it's not that big and not that easy to cut. Other mandatory spending, not that much. So where is all the money going to go on the spending side in the federal budget? It's going to go to Medicare, and it's going to go to Medicaid, and it's going to go to the subsidies under the Affordable Care Act. So there is no question that the most significant long-term spending challenge in this country in terms of the budget is getting hold of healthcare spending and of Medicare spending included in that. This is not an exhaustive list of options to reform the Medicare program and improve its finances, but it contains most of the major ideas that people have suggested. And I want to talk about one of them, and then I'll step through the rest. So the first idea up there is what I've talked about already, and that is the idea that we should change the payment and delivery system, that we have a healthcare system that is fragmented, a healthcare system that is built on places earning money based on the volume of care they provide rather than the quality of care that people get. And if we can change that system, and if we can change the incentives in payment, and if we can change the delivery system, then we can save money at the same time. And this includes a whole potpourri of solutions and ideas, such as the primary care medical home, doing a better job with primary care, looking at what works and what doesn't work in medical care, comparative effectiveness research. Moving away from fee-for-service payment, where we pay on the basis of each service provided, and instead we use what's called bundled payment. And so we pay hospitals for the care they provide in the hospital, but also make them responsible, for example, for 30 days after somebody is discharged. And the Affordable Care Act sets in motion a whole bunch of these, mainly in demonstration and pilot form. Just about every idea that every health services researcher has ever thought of is in the Affordable Care Act, and most of them are applied directly to Medicare. Now, I think that most of these are worth trying. I think many of them have good ideas, and I think some of them are going to be valuable even if they don't save money. I actually don't think that a healthcare policy that is built only on saving money is a very good policy. If some of these measures cost money but they improve quality of care, in my mind, they're worth it. On the other hand, I am skeptical as to whether these are going to be enough to rein in Medicare spending. This is what I like to call faith-based cost control. You have to believe it because the evidence is rather thin. And when you start looking at the evidence for each one of these and you start breaking it down, you say to yourself, well, there's a chance this could work. It could have potential, but we really don't have enough information to know that yet. So I don't believe this is going to be a reliable way of controlling spending in Medicare. How much of a contribution it makes, I think, is unknown, too much uncertainty. Another idea that has gained a lot of popularity in recent years is charging higher income Medicare beneficiaries more. And I'm sure that many of you have read Paul Krugman's columns talking about this issue, where he is nearly apoplectic about the idea. And I've always been confused by that for the simple reason that we already have income-related premiums in Medicare. Higher income Medicare beneficiaries, those who make over $85,000, pay more now for their premiums for Part B. But the idea is that we could increase what upper income Medicare beneficiaries pay and maybe increase the scope of the number of Medicare beneficiaries who are subject to income-related premiums. My own view is that this idea is justified. It's a form of progressive financing. On the other hand, I think there are two considerations we have to take into account. The first consideration is simply that we're not going to get that much money out of this. If you look at the income distribution of Medicare beneficiaries, and this is back in 2006, you can see that most Medicare beneficiaries are down here. So I don't know how we're going to define having high income. But if you want to say that, well, the top 25% of Medicare beneficiaries should have to pay higher premiums, we're going to be going fairly far down the income scale. There simply aren't enough wealthy Medicare beneficiaries to solve our problem this way. Simply not. The second thing we have to keep in mind is one of the dimensions that has made Medicare a special program is that it's universal. And Part B of Medicare, the physician part, is a voluntary program. People don't have to join it. And if we cut that subsidy so much that we cut it down to zero, we may find ourselves in a situation where some upper income Medicare beneficiaries opt out of the program and Medicare is no longer a universal program. There may be, we're not there yet, but there's probably out there somewhere a tipping point where we start to erode some of the universalism in Medicare, and I think we should proceed cautiously with that. Another idea that's very popular right now in Medicare policy is the notion that Medicare beneficiaries should have to pay more out of pocket, that they should have to pay more in terms of their deductible, more in terms of their cost sharing to help finance and meet this shortfall that we have in Medicare. Again, I think you can make a case for that, but on the other hand, it's worth noting that Medicare beneficiaries already pay a lot out of pocket. Medicare is not very good coverage. It's not as good as the standard coverage that people under 65 get at a large employer. On the hospital side, there's an $1,100 deductible, and by the way, you can meet that deductible more than once in a year. There's a 20% coinsurance charge for every physician visit and a $300 deductible for that, and lots of other things, including long-term care and nursing homes that Medicare doesn't cover. If you looked a decade ago, on average, Medicare beneficiaries spent 12% of their income on out-of-pocket costs for Medicare. It's now over 16%. So I think, again, the extent to which we're going to save lots of money by shifting costs to folks on Medicare is really quite limited. Another idea that is extremely popular in the Beltway is raising the eligibility age for Medicare. It's currently 65. There are a lot of proposals out there to move it, for example, to 67. And people make numerous arguments for this. They say, well, folks are living longer now, and they're longer in retirement, and so it's justified to move up the age that Social Security itself has been moving up in retirement age, that we have the health reform law, so there's a place now where what would have been Medicare beneficiaries who are age 65 and 66 can get health insurance coverage where they couldn't before. And most importantly, it'll save the federal government a lot of money. And I think this is a great example of some of the conventional wisdom in Medicare that is actually dead wrong. And I wanted to show this chart to explain why. It is true that if we move the retirement age from 65 to 67, the federal government will save money in the year that they picked here, just $6 billion. But if you cost it over a decade or over 2 decades, much more than that. The federal government can save a lot of money simply because they're covering fewer Medicare beneficiaries. They're waiting to age 67. The problem is, from a societal perspective, we're not, as far as I know, sending those Medicare beneficiaries to the moon. So they still have to get health insurance coverage somewhere. So where are they going to get coverage from? Well, some of them are actually going to be poor enough they're going to qualify for Medicaid. And so the states are going to pick some of that up. Many of them are going to get coverage from their employers. So the costs that would have been borne by the federal government are instead going to be borne by employers. The Medicare beneficiaries, their premiums, the folks that are 67 and older on Medicare, their premiums are actually going to go up. Why are their premiums going to go up? Because the healthiest people on Medicare are those who get there right now. Every time, if you're in Medicare and you see a 65-year-old, you should shake their hand and welcome them to Medicare because they're keeping your costs down because their average spending is lower. So if we take the lowest spending group and we cut them out, their costs go up. We also may send them into these new health insurance exchanges, these marketplaces that are part of the health reform law. Well, they're going to be the most expensive people in the exchanges. So when you look at the sum total of this, what you find is that, yes, the federal government saves money, but in fact, this reform would increase costs in the healthcare system. And in my mind, that epitomizes one of the problems in debates over Medicare policy. If we look at Medicare just as a problem of the federal budget, then we come up with solutions that simply reduce the federal budget, and we don't worry about spending in the healthcare system, system-wide spending. And if we do that, and we embrace solutions like this, we will reduce what the federal government's spending, but we're simply going to shift the cost. So this is not really a cost-saving reform. This is a cost-shifting reform. A bolder idea is that has been proposed by Paul Ryan, a Republican congressman from Wisconsin. And I want to deviate from my subject and talk about Medicaid. Medicaid doesn't get nearly the attention that Medicare does, and I think that's primarily because it takes care of a low-income population. And I want to talk about it for a minute. What Paul Ryan has proposed is to block grant Medicaid. That is, right now, on average, the federal government pays 57% of the costs for states in the Medicaid program. Under the Ryan approach, the federal government would instead have a fixed dollar amount that they would provide to states, regardless of how many people qualified for Medicaid in that state. He would also replace dual eligible coverage. These are folks who are on Medicare, but they're sufficiently low income that they have Medicaid as well. They have both programs. And he would replace the dual eligible coverage with medical savings accounts where you would put money in that could be used later to pay health care costs. Now, I think on the block grant side of this, it's important to say that if we went forward with block granting Medicaid to the levels that Paul Ryan has suggested, it would devastate the program. There's no question about that. We would have tens of millions of additional uninsured in this country because, again, we would not really be saving the system money. We would just be shifting and shafting to the states. And the states would be stuck with the bill, and either they're going to have to raise taxes a lot, or, which I think is more likely, they're just going to have to cut people off the Medicaid program. There are a lot of bad ideas in health policy. I've spent a career reading bad ideas. I'm not sure I've ever read an idea as bad as taking the dual eligible population and giving them medical savings accounts. This is a population that oftentimes is quite ill. They're quite low income. It comprises a lot of folks with disabilities and serious illness. And the idea that they're all of a sudden going to be using bank accounts and shopping around for medical care, I think is frankly insane. I'll tell you what I really think about it later. But the core of the Ryan proposal is really to replace the traditional Medicare program, the government part of Medicare, with a series of private insurance plans. There would be no government Medicare program anymore. There would simply be private plans, and Medicare beneficiaries would get a subsidy from the government, and they would get their coverage from one of these plans. That's really the core of the proposal for Medicare. And I wanted to show this chart from the Congressional Budget Office. And as John can tell you, the Congressional Budget Office has a well-deserved reputation for being nonpartisan, which is a nice way of saying both parties hate them because they come up with lots of inconvenient studies. And what they're doing here is comparing Medicare now as it exists with Medicare under this envisioned Ryan plan. So if you look at the top, what you see is this is traditional Medicare right now, and the government share of the cost, and beneficiaries share of the cost in the lighter blue. And above that is the cost if everybody was in a private insurance plan. The first thing to note is that according to the Congressional Budget Office, private insurance plans are 11% more expensive than traditional Medicare. Now, those who want to privatize Medicare have a great burden. They need to explain how it is we're going to save money in Medicare by shifting Medicare beneficiaries to more expensive plans. That's a kind of math that's very difficult to work out. The thing about the Ryan proposal and the subsidy in the Ryan proposal is it erodes over time. It doesn't, the value of that subsidy or voucher starts out pretty decently, but it doesn't do much over time. And so if you project out, as the Congressional Budget Office has, 2 decades from now, you'll see that in 2030, for a 65-year-old, a typical 65-year-old would have to pay 2/3 of his or her Medicare costs themselves. In other words, the Medicare program would be shrunk to the point where it would only be covering 1 out of every $3 for beneficiaries. And if you look at under this, which is under the traditional program, you can see that beneficiaries' share would be less than half of that. So again, the Ryan proposal is a great example of a plan that absolutely would reduce federal spending, absolutely would reduce federal spending on Medicare. But again, it's not cost-saving. Costs for Medicare beneficiaries actually would go up. The difference is the federal government wouldn't bear them. Medicare beneficiaries would bear them themselves. These costs would be shifted to them. Keep in mind as well, when we talk about transforming Medicare into a competitive market, Medicare comprises 39 million seniors, 8 million Americans under age 65 with disabilities. About half of the Medicare population makes less than 200% of the federal poverty level, and about 30% of the Medicare population has cognitive impairments. And so you have to ask, is this the population that is well designed for a program like this? Now, one of the arguments about privatizing Medicare or moving to a subsidy type system is that Medicare spending is uncontrollable. This is something you hear all the time in debates on Medicare, that we can't control program spending in Medicare. And so I brought this chart to show you that that's just not true. The way that the Congressional Budget Office likes to think about this is in terms of excess cost growth. And excess cost growth, what it means is beyond the amount that the economy is growing per capita, so beyond GDP growth, and beyond changes in aging, so increases we would expect from aging, how much is Medicare growing per capita above those two things? And you can see that over time, excess cost growth in Medicare has actually been going down and going down very significantly if you look at this dashed line here. And that's primarily because Medicare has been very aggressive in regulation and regulating what it pays hospitals and doctors. And those sorts of price regulations are crude, they're also effective. They're also effective. And so Medicare does not have a great record in cost control, but it does have a modestly successful record. And if you think about solutions for Medicare and reforms for Medicare, one reform that has worked for Medicare in the past, and I think we're going to use again in the future, is simply holding down payments to medical care providers in the program. That is something, as you see from this chart, that has worked before. It's something that we're going to do in the Affordable Care Act. And we seem to have forgotten the Affordable Care Act. And trust me, there are many parts of the last 2 years that I would like to forget. But again, the Affordable Care Act saves, projected, about $425 billion in Medicare over 10 years. And the best thing that we could do for Medicare in terms of slowing its spending growth is implement the provisions that are in the Affordable Care Act for Medicare, which is no sure thing. If we could implement those provisions, Medicare spending will go down substantially. Since 1975, on average, Medicare spending has grown about 2.5 percentage points faster than GDP growth, faster and measured this way. But if we take account of those projected savings in the Affordable Care Act, and even if we take account of fixing the Medicare physician payment problem, what's called the SGR formula in Medicare, it's going to cost $250, $300 billion to fix. If you look at the next decade, Medicare's growth rate in excess of GDP and population aging is 0.2%, not 2%, projected to be 0.2%. Now, we may be able to get it lower than that, but we're not going to be able to go much lower than that. So simply implementing the Affordable Care Act is probably the best thing that we can do for the program. Even if we do that, however, there's no question that Medicare spending is going to grow in the next couple decades. And the reason it's going to grow is not growth in per capita spending, but growth in the capita, in other words, enrollment growth. And if you look at this chart, you'll see the next 2 decades, the effects of the baby boom generation. Medicare right now is taking on about 1.5 million new beneficiaries every year. And so for the next 2 decades, demography is going to play a very important role in Medicare spending. Now, that's not a crisis. If you wanted the perfect Medicare patient, after all, from a budgetary perspective, it would be a person who is fairly healthy, who had a high-paying job and paid lots of payroll taxes, and then they died at age 64 before they could claim Medicare benefits. That would be wonderful from the CBO perspective. From a budget perspective, I think it'd be pretty bad from a social perspective. The fact that people are living longer is not a problem. It's actually a good thing, I think, on average. So the fact that Medicare is there to take in the baby boomers is not a crisis, in my view. We should be glad that Medicare is there. And we should not confuse the fact that more people are going to be on Medicare with an increase in national health spending. These folks are simply coming from the private sector and going on to the public sector. But they're still part of national health care spending. It's simply the source of that spending is going to change from private to public. The demographic problem or pressures on Medicare reinforce this idea that our healthcare spending problem is a budget problem. And as I said before, I don't think that's a very good way of looking at healthcare. We don't have a Medicare spending problem in this country. We have a healthcare spending problem. We spend $2.6 trillion, over 17% of our economy is on healthcare. And it's not just about the federal government. And as you can see here, this is showing you how much health insurance premiums have gone up in the last decade and how little workers' wages have gone up, adjusted for inflation, virtually nothing in the past decade, mainly because they're going to pay for those healthcare costs. So what we need is not a solution to Medicare rising costs. We need a system-wide solution. We will not control Medicare spending reliably if we do not also control rising spending in the broader healthcare system. It's just not going to happen. So what could we do? Well, one thing we could do is look at the example of other countries who, after all, provide universal coverage and spend much less than we do on medical care, and many of whom have very good quality of care. This was a study that was done last year comparing our neighbors to the north, Canada, and us, and asking what explains the difference for hospitals and physicians? What explains the difference? And what they found in this study is that the biggest single explanation of why U.S. medical care spending was higher was administrative costs. Why are American administrative costs higher? Because we have a multi-payer system with lots of different insurance companies with lots of different rules, and that creates huge administrative costs and burdens for physicians, for hospitals, and for the insurance companies themselves. Canada, of course, doesn't have any of that. Another reason, major reason that our spending is higher in this country is simply prices. We pay more, and people make more money for the same services. And a final reason is there are some high-tech things that we do more of, but notice that is not a major explanation. Now, if I had a chart up here of what U.S. health policy analysts focus on, it would probably say care received 90%, prices and administration 5% each. Our debate in the United States is dominated by the obsession with reducing utilization, and there is a lot of utilization in Medicare and outside Medicare that's expensive and low value. But I would suggest that if we want to get hold of the healthcare spending problem in the country, we're going to have to do something about administration and pricing. Now, we're not going to move anytime soon to a single payer program. If the United States was comprised of Berkeley, Madison, and Chapel Hill, maybe we would, but it's not. So what might be another way we could go? Another way that we could go, no time soon, but maybe in the not-too-distant future, is what's called an all-payer healthcare system. And this is exemplified in places like Japan and Germany, where they have multiple insurance companies, but they have one set of rules. In a given region, there is one fee schedule. And you avoid the problem there of administrative costs being high because there's one set of rules. You avoid price discrimination. One of the problems we have right now in this country, and it's only going to get worse over time, is that as the budget pressures focus on Medicare, Medicare is going to try and lower what it pays medical care providers. And there's going to be a gap, which there is already, between the private sector and private insurers that pay more than Medicare. If that gap becomes too much over time, Medicare beneficiaries in some situation in some areas of the country are going to have their access eroded. So for that reason as well, I think we would do well to adopt some of the all-payer approaches. Another alternative for Medicare, and one that no politician wants to admit to, is raising revenue, raising taxes. And if there's one thing I can tell you with absolute certainty that I know about the future, and that you can call me on 10 or 15 years from now, it's that if we want to maintain the Medicare program that we have and Medicaid and Social Security, we are going to have to raise taxes. There's just no question about it. We talk about the deficit problem, and the deficit problem is not just the result of the spending side, it's also on the tax side. And we're going to have to raise taxes if we want to keep the programs that we're accustomed to in this country. Nobody likes paying higher taxes, and many Americans feel overtaxed. But if you see up on this chart, compared to other industrialized democracies, and what this chart is showing you is total tax revenues as a percent of the economy, the United States is fairly low. We're towards the bottom of the distribution there, hanging out with Turkey and Mexico and Japan. Now, we don't need to go up to Denmark or Sweden, but we are going to have to go up maybe closer to the average in the OECD, which is an organization of the rich democracies. We're simply going to have to raise revenues, or we do not have a realistic chance to close this long-term budget gap. We simply don't, unless we're willing to gut the programs that we just talked about. The political environment is going to be very important for Medicare, and I think one of these four people is going to be president. I'm not sure which one, but one of the four, and I made a recent addition to this chart. You can probably figure out who. So Medicare's future is very much affected by the 2012 elections. And the 2012 elections are going to be fought on many issues, predominantly the economy. But there's no policy area that's going to be affected more than health care. And I said that Medicare's fate is tied partly with the Affordable Care Act and partly with this wider debate over repealing the Affordable Care Act. And the chances for repeal depend greatly on who wins the election. If Mitt Romney or Rick Perry or Herman Cain are elected president with a Republican Senate and a Republican House, they will attempt to repeal the Affordable Care Act. Now, it doesn't mean they're going to be successful. They're going to have some obstacles in their way, but there's a good chance that they can take out a good part of it. On the other hand, if Barack Obama is reelected, the Affordable Care Act will march, or probably more accurately, stumble on. But very different political environments for Medicare. Medicare politics are difficult, and there are a lot of contradictions about Medicare. This photo is from back in the 2009, summer of 2009, during the Tea Party debates. And this woman was part of a Tea Party debate and held up a sign that was very popular, "Don't touch my Medicare." We don't want your government health program, but don't touch my Medicare. So Medicare, which of course is a government program, is part of the status quo. And there's this interesting political competition going on for who is going to be the party of Medicare. When Paul Ryan came out with his plan, as you know, here in New York, he gave Democrats a great gift. They could run against Republicans as trying to demolish Medicare. And Democrats used that strategy very effectively in the special election in upstate New York, and they used it so well, it worked so well, they decided to abandon it. And so then President Obama came out sort of with his proposals with Speaker Boehner about raising the eligibility age for Medicare, and they sort of forfeited that ground. So it's going back and forth, and is, I think, a very interesting political question going into 2012 and beyond. Who is going to be the party of Medicare? Is there going to be a party of Medicare, and what are the positions going to be? One thing to note about this is that the political debate over Medicare is affected by the wider environment. And this is a chart that political scientists like to show. What this is showing the ideological distance between Republicans and Democrats all the way back to the the period right after the Civil War. And this comes from folks at MIT who apparently have nothing better to do than count all the roll call votes in American history dating all the way back to the Civil War, but I think they have better computers than I own. And what they found is this. If you look at it over time, you can see there was a period, and here we have the Dixiecrats, the Southern Democrats, the Conservative Coalition, or as we call them today, the Blue Dogs, and you can see the distance between the two parties. But then what happens over time, Republicans move to the right, Democrats move down to the left, and by the way, the number of Southern Democrats who are around moves down. And so now we have a political environment in Congress that is polarized. It is more polarized along ideological and partisan lines in Congress than at any period since the 1870s. And what that means, I think, for Medicare is that more conflict is ahead. Because when you have a $500 billion program, when you have a debate about the budget deficit that program is connected to, when you have a program that touches on fundamental questions of markets and ideology and individualism and the opportunity and equality, and you throw that sort of program and that debate into this environment, you're going to get a very polarized debate. So no matter who wins the next election, for the time being, I think you're going to see a lot of fighting over Medicare because the stakes are that high. So I learned very advanced methods in graduate school in political science, and this is one of my colleagues trying his hand. What's the future going to be for Medicare? Well, I don't know. There are several different ways it could go. There's no question that Medicare, as an important part of the American safety net, as a critical part of the health insurance system, no question in my mind that it's going to remain. It's going to be there. What sort of changes are more likely to happen? Well, I think higher income Medicare beneficiaries are going to have to pay more. I think all Medicare beneficiaries are going to pay a bit more in costs. Raising the eligibility age, there's some support for that in the Democratic Party, a lot of support in the Republican Party, so that has a decent chance of happening. I think the big collision on Medicare is going to be over something like the Ryan plan, over a structural change to Medicare to move it in a more market direction. And there, as I said before, the fortunes for that one are unclear. It really depends on how the elections turn out, not just in 2012 and beyond. And so I don't know which direction Medicare is going. What I do know is this. Nearly 50 years after it was created, the Medicare debate is nowhere near over. Thank you very much.
Thank you, John. We're going to hear from John Palmer next.
Grant keeps bringing in these short speakers, and then I have to bring my portable podium. Well, I've always been an appreciative consumer of Professor Oberlander's work on Medicare, and what we heard this afternoon is no exception. As a public trustee, I benefited from his many writings on the history and politics of Medicare, which informed the astute tour that he just took us on of the future of the program. Not surprisingly, I find myself in general agreement with everything he had to say today. And I want to just focus in a little on some of the more green eye shade budget stuff, since that's what I worried about more as a trustee, the fiscal dimensions. And here, I do believe, if anything, he understated the difficulty of the fiscal challenge that's presented by Medicare. And let me just briefly elaborate on why I say that. As he observed, at the heart of the United States long-term deficit and debt problem is the fact that under current policies and projected growth of Medicare spending on health care in general far outstrip the sources of financing available for them. And this is particularly true for Medicare, which accounts for the majority of that federal health spending on health care. John didn't go into this in any detail, but in fact, outlays for Medicare are projected to double in size relative to the economy over the next 25 years in the projections that he showed you at a more general level. from about 3.5% of GDP now to 7% of GDP, while revenue sources increase very little. And most of this doubling, as he emphasized, is due to the growth in Medicare enrollment, which is expected to leap actually from about 45 million today to more like 85 million people over this same 25-year period. And only a small share due to the age-adjusted per capita healthcare costs rising faster than incomes, the so-called excess cost growth that he described using CBO terminology. And in fact, as he mentioned, due to the provisions in Healthcare Reform Act, which greatly constrain non-physician payments over the next several decades, particularly those to hospitals, to help finance the coverage and expansion that's under the Affordable Care Act. The projections for federal health care spending, again, despite how rapidly they go up, assume essentially zero excess cost growth in Medicare over this period. He mentioned 0.2 per year is built into those assumptions. And this is in stark contrast to the cost per enrollee growing much faster than GDP per capita by an average of about 17% a year, or 17% over each of the last 2 decades. So we're now projecting essentially zero growth relative to the economy going forward in these projections, whereas it has been about 17% over the past decade, each of the past 2. And the difficulty with such a course for Medicare provider payments is that the actual underlying cost increases for treating Medicare patients are unlikely to be similarly arrested over this period of time. Due to past stringencies in Medicare payments that Jonathan alluded to, we have squeezed down provider payments to a great extent to where they're only now, on average, about 80% under Medicare as to what's paid by private insurance for the same or comparable services. And under these projections that we're seeing, that continued stringencies that are even more strict under the Affordable Care Act would bring that down over a decade to under 70%. Well, Medicaid's now paying 70% of private health insurance. And we know what kinds of concerns are raised there about access to quality care for Medicaid recipients. Imagine what the reaction will be with Medicare payments going down to a level that's even below where Medicaid payments currently are. But that's what we're facing. And that's part of the reason why the sign being held up that he mentioned, "Don't touch my Medicare." It was the Republicans pointing out that these kinds of cuts were likely to have those kinds of consequences over the next decade. So continuing or having a prolonged continued squeeze on Medicare payments is not really that tenable, certainly not beyond the next decade, if even that long, unless healthcare reform does result in major changes in general healthcare delivery and payment systems that in turn lead to dramatic cost savings and changes in the practice of medicine in this country, about which Jonathan mentioned and was skeptical that we could expect much over the next decade or 2 at least as a direct result of healthcare reform. So this perspective on the ability to save costs through reimbursement, coupled together with what he said about all the other potential cost-saving measures, suggests that, revenue increases is really going to be where we're going to have to look to put Medicare on a more sustained fiscal basis down the road. And I expect that there will be some in that regard. But here, too, I'm a little less sanguine than Professor Oberlander. Yes, tax burdens are much lower in the United States than is typical of other rich countries, and arguably could increase considerably without compromising our economic vitality if our tax structure were better designed than it is. But we need to keep 2 things in mind here. First, our tax burdens are lower in the United States in part because unlike the other rich countries that he showed us, we pay for a large share of our health care, more than half, through private and not public means. And those private share, that large private share we now pay, will not be declining as we increase tax burdens for strengthening Medicare. So you have to take into account that they're outside of that data he showed us for us, but they're inside the data, those private costs that we do privately. They're inside the tax burdens for other countries who have comprehensive health coverage through the public sector. And secondly, he showed us that the total tax burden is 26% of GDP in this country. Less than 15% of that is actually, in 210, is attributable to the federal tax burden. The rest is the state and local level. And that is well below the historical norms for federal tax burdens in this country over the last 4 or 5 decades due to the poor performance of the economy in recent years. But a 1/4 increase in federal tax burdens relative to that less than 15% is already baked into the cake under current policies and is already inherent in the projections that he showed us. Because as we recover from the weak economy, those tax burdens will increase without any change in policies. So any additional taxes that we raise to bolster Medicare financing are going to be above and beyond that and take us well above what historical norms have been with respect to federal tax burdens. It's not to say we don't have to contemplate and consider it, but it's not going to be easily or lightly done, as I think Jonathan knows well. So we really are, I think, caught between the proverbial rock and a hard place with respect to either thinking that we're going to make much progress easily on restraining costs, particularly through screwing down more on provider payments in the near future, or through increasing revenues. That's nothing that I think John would disagree with. I just wanted to spell those dimensions of what he had to say out a little bit more and indicate why he might have come across as even being a little more optimistic than he usually is on those dimensions than I think is probably warranted. So those are my views. Tom?
Thank you.
Tom Dennison.
In general, I'm really in favor of the direction that the healthcare reform legislation is going. It increases coverage for people who are uninsured. It reforms some of the more egregious parts of the insurance industry's practices. It increases public health spending. It expands Medicare beyond the notion of simply diagnosis and treatment and extends to prevention with some covered benefits. Those are all really very good things. But I am a former hospital administrator. And wearing that hat and looking at the healthcare reform legislation through the lens of a hospital administrator, I really would join the ranks of the people who are popping champagne corks if the Supreme Court were to rule that healthcare reform is unconstitutional and is abandoned. Why? Well, Jonathan said that half the funds that will cover the uninsured will come from savings from Medicare, reductions in payments. John Palmer echoed that. Much of that will come from hospitals. As John said, hospitals are currently paid 80 to 90% of their costs from Medicare. They're paid 70% of their cost from Medicaid, and the difference is made up by private insurance companies who pay 130% or so of the average cost so that you can break even at some level. So what happens? Medicare payments go down under healthcare reform, and Jonathan said that Medicare patients might have decreased access. That doesn't worry me as much as the fact that the providers will go to the bank, the private insurance companies, and say, look, we need higher rates. And if they succeed, the premiums go up, the health insurance premiums go up, employees and employers, you and I, will have to pay more, and at some point, there is a tipping point where employers say, done with this, can't continue to offer employer-based health insurance. It pushes those employees, or employees say, yeah, it's a nice insurance plan that you're offering to me, but I can no longer afford the 30% or 40% of the cost sharing you'd like to introduce. I can't afford it. So it truly becomes unaffordable. That means that you'll be pushed out into the market, And even though the exchanges will be there, the premiums will be so high that you won't be able to afford the insurance. There are penalties associated with not purchasing health insurance in healthcare reform as it's currently structured. Those payments, those fines will be nominal compared to the premiums that you'd have to pay if you were to purchase healthcare insurance. So if Medicare is used as the bank to pay for extending coverage to others, to the uninsured, the dominoes start to fall. And when the dominoes start to fall, the costs in the other parts of the system truly become unsustainable. So what does all this mean? Medicare cannot be looked at independently. The future of Medicare is so intertwined with the future of the rest of the healthcare system that it's almost futile to try to look at the future of Medicare and think about it as an independent part of the delivery system. And as Jonathan pointed out, and many of the strategies that we're talking about is simply cost shifting or moving the deck chairs around on the Titanic. So my overall comment is that you really can't think about Medicare independently of the future of the rest of the healthcare system. I agree with Jonathan that healthcare needs a system-wide solution. An all-payer system might be one of those strategies. We really need to look at reduction in overall cost. We don't really need to focus on trying to solve one part of the puzzle. Rather, we need to solve the entire puzzle at once.
Thanks to the two of you for that. John, do you want to have a very, very quick response to those two things, and then we'll open it up for questions for all three of you? Do it there,
sure.
or here? I think your mic.
Well,
yeah.
it's an unusual position for me to be in, to be the optimist in a group. So I've got somebody who's admittedly pessimistic and somebody else who's citing the Titanic. So I'll take that middle course. I think we're actually broadly in agreement here. I don't think any of the things that the three of us have discussed are going to be easy. I don't think raising taxes is politically easy. I don't think holding down provider payments is politically easy. I don't think shifting costs to beneficiaries is politically easy. None of this stuff is easy. And whatever else happens, we are going to be spending more of our GDP in the future on Medicare. And that's not necessarily a bad thing, because a big percent of the population is going to be on Medicare. And in many ways, what this boils down to is not an economic choice, but a social choice. How much are we as a society willing to spend on seniors and those with disabilities on health care? And just to, again, reinforce what was said, I think the obsession in Washington with Medicare as a budget problem echoed in the media distracts us from this broader issue of controlling healthcare spending in the entire system. And if we don't do that as a country, then certainly Medicare is not going to fare very well.
Thanks. So who wants to pose a question or make a point? And please wait for the microphone to come to you so that we can have you as be part of our archive that we make of these events. Here, we've got a gentleman right here. There you go. Thank you.
Yeah, thanks. I don't know what percentage drug costs are of the overall picture, but why isn't any attack made on the extremely high cost of medications? It seems like we're grossly overpaying for them.
They're small potatoes compared to hospital and physician costs are growing, but they're a smaller amount. But people are going after them. If you look at the president's proposal from September, the single largest item that he proposed in saving money in Medicare was to reduce what Medicare is paying in drug costs from low-income beneficiaries. And I'm sure that's part of the Democratic unreleased supercommittee plan. So I think you're going to see more attempts to go after drug spending as we've gone after hospitals and physicians in the past.
Good.
Somebody else? Gentleman right back there.
Hi. I was wondering what's the status on the trials to move away from fee-for-service, whether it's like patient-centered medical homes or bundled payments, or just what's the general direction those pilot programs are moving in? Have they been started? If so, how successful have they been? Because it seems like moving away possibly from the fee-for-service system could be a big change for the entire healthcare system, independent of Medicare alone.
Yeah, I'll make a comment, and then maybe John and Tom want to add. Have you ever taken on a really windy day, a piece of paper, torn it up, and thrown it in the air? that's the direction that it's moving in. And maybe I'll start a little bit of controversy here. I actually think that in some ways the obsession of moving away from fee-for-service is misdirected. I don't think fee-for-service is a great system. I think it has inflationary incentives, but when I read that the reason that the U.S. has high healthcare spending is fee-for-service payment to doctors, I scratch my head because Canada has fee-for-service payment to physicians. Germany has had it. Japan has had it. They all spend much lower than we do. So the problem, I think, is not fee-for-service per se, it's the fee that we're paying here in the United States. Having said that, I think there's certainly some potential to get some efficiency there and maybe some quality gains. It depends how broadly you want to define attempts. You can go back to Kaiser Permanente and you can go back to the beginning of the 20th century and find islands of difference in the United States that don't pay fee-for-service. Most recently, the VA, which has had very good results in their healthcare reform. If you're talking about the efforts in the 2010 law, they're sort of nascent, and we just had 696 pages of regulations released on accountable care organizations, which I have not read, but I'll get back to you on. So I think those attempts are ongoing. It's certainly paying hospitals in a way that shifts risk to them is a very popular idea with insurers, public and private, and I think we're going to see more of that. And you all may want to add.
Well, I agree completely that the real issue is the price, and the other piece that's a real issue is the administrative complexity and the cost and noise associated with administering the system. I think that the kind of demonstrations we're talking about have more benefit potentially in improving the continuity of care and the quality of care than they do ratcheting down costs.
And I mean, I think that's right. And there's a lot that's going to be tried that's not really underway in these regards. There are some smaller experiments going on at the state level, but now the federal government is going to get into supporting this in a much bigger way. But I think the conclusions will be what you heard from them. And until we eventually, as a society, decide we're going to try to control the prices more rigorously and implement a kind of rationing on more cost-effective spaces, we're not going to see a major decline in the growth path of healthcare spending in this country. We're eventually going to have to do some of the things that other countries do that we've shied away from doing.
And just to echo on the quality side, because we've been focused on the financing, there are a lot of gaps in quality of care in Medicare, as there are in the broader system. And we have a healthcare delivery system that's fragmented, that's not well coordinated, where all too often we are not providing people, especially who are chronically ill or have a very complicated illness, with the kind of care that they need. And that's why I said before that I think it's a mistake to judge these experiments just by whether they save money, because if medical homes improve primary care and accountable care organizations somehow stimulate hospitals to have better coordinated care and they cost money, that's probably a pretty good investment.
If I hear you correctly, you all agree on two things. The problem is system-wide, and the point of attack is price. So what you going to do? How are you going to fix the prices? Either stabilize them or drive them down. System-wide.
We're all willing to answer.
It seems so.
I'm happy to go. So an all-payer system tells you how you can set prices and that everybody would be paying the same. It doesn't say at what level. And I think part of the problem is we've got to recalibrate prices, not just move in one direction. I actually think that the prices for some aspects of primary care are underpriced. I spend a lot of my time teaching medical students, and to be honest, the message that we're sending medical students as a society is we don't value primary care. I don't know what it's like at Syracuse, but I interview for admission in medical school at University of North Carolina, or I used to. And every student in every year that I ever interviewed, when I asked them what kind of medicine do you want to practice, they said primary care. And so when the guy who runs rural health care for the state came and talked about this primary care shortage in North Carolina, I said, what are you talking about? Every medical student says they're going into primary care. But of course, when they get further along in medical school, they see, well, we don't really value primary care. So I actually think we need to bump primary care up. Some of the procedures we probably need to bump down, and we sure don't need to pay at where private insurers do for hospitals. Where exactly the correct rate is, I'll leave to the hospital CEO.
You asked, what are we going to do? And my answer is, in a sense, I mean, I agree again with what Jonathan said. I think the things that we're eventually going to have to do, we are simply not prepared as a society to do. And I think it's going to take quite a while before we stumble into that. And that's why I'm particularly pessimistic about how things are going to go for the next decade or two.
So the price side.
So we're going to run up debt more.
The price side of this is
healthcare
just
costs.
as hard as the spending side.
Yes, very much so.
Absolutely.
The political power of the people who are getting the big dollars is very, very strong. And there's a great deal of opposition. There has been a great deal of opposition to this since the 1930s by organized medicine. So it's not something that just happened. And I do agree with Jonathan, there does need to be recalibration. There are places in the system where we are underpaying primary care, mental health, as an example, home health aides, personal care workers, the frontline staff, they are underpaid, but we have pieces of the system where we're grossly overpaid. Remember, too, though, this is nearly 1/6 of the U.S. economy, and every dollar that is excess spending is a dollar of revenue to somebody. Healthcare is the largest employer in this community, so if we were to wholesale reduce spending in healthcare, it could be quite a challenge to our tax base and our economic strength.
And the other thing I would just say to keep in mind is nobody is really talking about reducing the absolute level of healthcare spending. We're talking about reducing the trajectory from this to this. And so if you look and you say, what is the official government estimate of how much are we projected to spend in the entire healthcare system in the next decade, it's $35 trillion. And if you take the most optimistic estimate from the Commonwealth Fund on savings from the Affordable Care Act, it brings us all the way down to $34.4 trillion. So this is a growth industry.
Let me ask a quick follow-up to Bob's question, based, John Oberlander, on your response. Are there other countries in the world that have made a conscious effort to change that price structure toward primary care physicians and have been successful with it that have any relevance at all for us?
Yeah, we are a particularly specialty-oriented country in many ways, and in our pricing. And if you look at other places like Japan, you'll see that they aggressively hold down prices for certain kinds of medical specialists in a way that we just haven't been willing to do politically.
But no other country.
The short answer is almost all the other rich countries.
Almost all.
Except no other country has ever let it get to the point where we have and had to cut back. They just never let it get that bad.
Other questions? Gentlemen here. Oh, let's get the student down here first. We'll get the student down here first, and we'll come back and get you in a minute, sir.
Do you believe that going forward that the federal government should take on more of a role to reduce the cost, or do you think maybe that some more of the responsibility should be put on the states to maybe avoid some constitutionality issues?
Well, it depends what aspect of the system we're talking about. Medicare, of course, is at the federal level. Medicaid,
like regulating hospitals.
Federal, state, and hospitals. I don't think the states can handle this. There are lots of states that do lots of good and interesting things on medical care spending. I think the problem is a national problem. I think it's just something that's too big for them, and it's going to have to be federal.
As I'm involved in counseling people with Medicare-related insurance plans, I'm concerned about private insurance companies. I don't think you've directly answered that today, but is there any way to at least hold down some of their rising costs, you see?
Yeah, you're talking about the Medicare Advantage plans?
No, not just Medicare Advantage. Insurance companies are heavily involved in regular Medicare with the Medigap plans, as well as Medicare Advantage, as well as Part D drug plans.
Yeah. So you're right that Medicare is really a hybrid program, and we probably don't talk enough about it in that hybrid way. 1 out of every 4 Medicare beneficiaries is actually already in a private insurance plan, one of these Medicare Advantage plans right now, and they're paid on average about $1,100 more per person than it costs for every person they enroll. So I always tell my public health business students that they shouldn't listen to anything I teach them, and they then reply, we don't. But if they really want to know how to make money in the healthcare system, just go and set up a Medicare Advantage plan, because it's easy pickings. The Affordable Care Act brings that down. In terms of Medigap is an area that we've tried to regulate, and we've put letters on it and done all sorts of things, and it's better than it used to be, but it's still not there. And I think one thing that the Part D experience with private plans tells us is, on the one hand, the spending side of that has been mixed depending on which metric you judge it by, but there's just been rampant confusion, which I guess is good for you, but there's been terrible confusion among Medicare beneficiaries, and when you give people 2 dozen, 3 dozen, 4 dozen choices, at some point it just becomes overwhelming. And I think actually one thing the Obama administration is moving to do in that market is they're actually starting to move to take some of those plans out that aren't high quality plans. And we need to think about choice, not simply as a good in and of itself, but you can also have too much choice that is paralyzing and confusing and makes it very difficult to regulate. And that's what we've got in some sense in those markets.
Another aspect that, beyond what Jonathan just talked about, was inherent in our remarks earlier, is as you screw down on the provider reimbursement in Medicare, it's going to have 2 consequences that are in tension with each other, and we don't know which one's going to dominate. One is it might actually force increased efficiencies and productivity increases in the healthcare sector, which is incredibly inefficient now in many respects, and in that way begin to have a salutary impact on bending the cost curve. On the other hand, it's going to cause cost shifting potentially, because Medicare is going to cover a lower and lower share of actual costs over to private insurance, and that will drive up even more, potentially, the increases in private insurance. So how those 2 things play out, and we don't know, because this is a very complex system, and when you push something in here, you just don't know how it's going to play out throughout the whole system. It's going to make a big difference.
I want to ask a question about data. When you're looking at Medicare Advantage plans and you're talking about getting rid of the non-quality plans, the way that they're going to do that is they're going to determine which plans, a big part of that on this star rating thing is, which plans are doing the best job of identifying complex patients. And the way they're getting that data, and we know because we're dealing with it every day, is they're going to the providers. They've created a whole layer, a whole new industry that's going into these providers' offices and making massive copies of charts and going in and data mining for complexities, which is causing huge burdens on particularly primary care physicians who there aren't enough of to provide the care. And they're taking that data, they're handing it back to Medicare, supposedly. Medicare is using it to assess them and paying them more per member per month so that they can rake in more dollars. And at the end of the day, the doctor doesn't get more for doing that work. The hospital doesn't get more for doing that work. The patient doesn't get better care. The insurance company gets a bigger paycheck. And if we really believed, and I've asked the insurers, okay, so are you collecting this data and thereby analyzing your patient population and crafting programs that then better serve those patients to improve the way we coordinate the care, provide the care, and improve outcomes, then maybe everybody would be okay with this. But I see absolutely no evidence that's happening. So as you get all these little units of data, you have no ability. Medicare is a fabulous treasure trove of data that's not been mined really at all to look at any kind of outcome measure or anything. So as we do all these things for economic reasons, we're not looking at outcome data. And we're really penalizing ourselves in terms of what we have as a system of information. And every other country does a really good job, I think, of trying to look at that data, and we're really not doing it. So how are we going to do that?
I don't know. It's a really interesting point. I think the other thing that was implicit in what all three of us said is we don't have a healthcare system in this country. We're talking about coordinating Medicare and Medicaid and private insurance, let alone coordinating within Medicare and the different parts of Medicare. And when you get a case like this, it really illustrates that.
Yeah, thanks. Could you elaborate a bit on the prospects of employers and employees looking at the reality they're going to face in the next 5 to 10 years, and more of them leaving employer-sponsored group plans and going into the exchanges, and the impact that's likely to have or could potentially have on the need for subsidies, which may be possibly underestimated in the CBO projections, so that we could be looking at costs that are really a lot more alarming than they appear to be at the moment?
Yeah. First of all, I think there's a decent chance that the exchanges are going to be repealed. So assuming that the exchanges are not repealed, I think your point is well taken. A decade ago, roughly 69% or so of American businesses offered health insurance. Now it's down to 59 or 60%. There are reasons to think it's going to continue to fray. And if it frays more than the Congressional Budget Office is projecting, and none of us talked about this other set of projections about the health reform law, then you're right. Then more people will be eligible for the exchanges, and there'll be more government subsidies. I think that's a great unknown. On the one hand, you hear stories of places like Caterpillar that say, we've done the math, it's cheaper for us to get out of this business. On the other hand, most of those businesses don't have to provide coverage now, and they do. And they do for economic reasons. And if we use Massachusetts as a case study, when they adopted their very similar healthcare reform law, their level of employer-sponsored insurance didn't decline. It actually went up a little bit. Whether that's going to play out in the other states, I don't know, but I would worry as well just about the state of the economy. And if we slip back into recession and there's a higher unemployment rate, the same dynamic's going to happen with fewer people having access to employer-sponsored coverage, more people eligible for Medicaid or the exchanges, and a shortfall of subsidies. And we haven't talked about the financing of the Affordable Care Act, but I think there's a great amount of uncertainty about that. I will have to make a Silvio slide for next time.
Yeah, I mean, the great uncertainty here that Jonathan ended with is you can't overemphasize that in terms of how these things might play out. But it's also true there's employers who are going to be penalized under the Affordable Care Act to the extent that their employees do go into the exchanges. So that's a stick. They might decide to do that, but then if they do in the exchanges, that isn't necessarily such a bad idea when you think about it system-wide. It'll increase federal costs, but it won't necessarily increase overall costs. In fact, the more go into the exchanges, the more competitive marketplaces the exchanges might be, and that's one of the things that everybody hopes will help hold down private insurance costs over time.
There are also the American employers are Jekyll and Hyde. On the one hand, they complain about the cost of health insurance, and they complain that employer-sponsored coverage is bankrupting them. On the other hand, they generally don't support efforts to move away from employer-sponsored insurance. And during the health reform debate, there were efforts by Ron Wyden and others to enlarge the scope of the exchanges and bring large employers and other employers in the exchanges. And they opposed them because they said, well, we think we're going to end up paying one way or another. We'd rather control it ourselves. So they're sort of two minds on it.
One more quick question.
Thank you. I was wondering if you had anything or any comments on the legal side of healthcare in terms of both pharmaceuticals and their effectiveness with drugs and litigation associated with that, and also what is termed as defensive medicine by doctors to really try to avoid malpractice lawsuits.
On the drug side, I can't help you because that's not my expertise, and maybe somebody up here will know more than me, which won't be difficult on that. On the defensive medicine, the reason I know I'm not giving a talk at a medical school is that wasn't the first question, because it would be at a medical school. There's no question that our malpractice system is not a very good system. It doesn't do what it's supposed to do. It doesn't improve quality of care. It doesn't reward people and compensate people fairly who have been injured. So it's just not a very good system overall. If you try and measure the cost of defensive medicine, it's a very, very difficult thing to measure. The best estimate that we have is that it adds to U.S. healthcare spending, but at a fairly modest rate, and so I think, I would be for reforming the malpractice system, even if it doesn't save $1, because it doesn't work well. I'd like to see us go to a no-fault kind of system. But even if we have reform in the malpractice system, a la Texas, what you're probably going to find is you're going to reduce penalties. You can and awards what people get, but you're not going to slow down healthcare spending very much.
Yeah, I too am not an expert on the drug issue, but with respect to the malpractice and defensive medicine, it is only roughly 6%, we think, or so. So even if you were to reduce that by half, you're not talking about enough money to save the system itself. But I agree with Jonathan, it's broken and it should be fixed.
Well, I don't know if this makes me an optimist or a pessimist, but somehow, some way, I feel a little better about all this than I did an hour and a half ago, but I want to thank all three of you, and particularly Jonathan Oberlander, for helping us figure this out. Thank you.